Hello, everyone. My name is Amiethab Aiyer, and I'm the Chief of the Foot and Ankle Service on the Department of Orthopaedics at Johns Hopkins University School of Medicine. And today we'll be discussing minimally invasive hallux valgus correction and a study that was done recently by myself and some of my colleagues back in Florida, actually. Here are some disclosures of mine. Hallux valgus, or a bunion as it's commonly called, is pretty common in the front of the foot, and its prevalence increases with age, and it's more common in females. Many patients may complain of shoe wear issues, particularly with pain with shoe wear specifically. And when conservative measures, as described here, fail, surgery is often indicated for these patients. There's multiple surgeries. So if you type in, bunion correction into Dr. Google, you'll find that there's a zillion ways to skin a cat, so to speak, and that involves bony correction, soft tissue correction, just a handful of ways to actually address this. And as the deformity gets more severe, we usually have to kind of move towards the mid portion of the back of the foot in order to address how severe the deformity is in actuality. And so with this in mind, and because, more severe deformities may require bigger incisions and the like, there's been the advent of, minimally invasive techniques that have sort of spanned three different generational ideas. The first of which being, hey, let's just cut the metatarsal head as seen here, where the arrow is kind of delineating. And let's just, try to shift the head and not put any sort of fixation in there. The second generation is when we cut and shift the head, and interestingly enough, we go ahead and just put a pin into place. And then the third generation, probably the more common and current generation, is where we actually cut and shift the head using special tools in the operating room, and then actually use screws, as you can see here, usually 1, 2, and 3, in order to hold the great toe in an improved position, if you will, improved alignment, both clinically and radiographically or on X-ray. So there have been, multiple studies across the globe trying to better understand what is the clinical significance of doing either minimally invasive versus open procedures. And even in the last year or so, including some of my, dear friends and colleagues from around the country, the minimally invasive procedures have been shown to have low complication rates, decrease in opioid consumption postoperatively, and overall, pretty good function as a result. And so what's been studied and the overall results just demonstrate that there's improved postoperative pain, especially in the first week, reduced operating room time, blood loss, wound healing complications. And this leads to the ability to rehabilitate these patients a little more aggressively, greater patient satisfaction overall, and decreased narcotic use. And of course, this is sort of not every patient is, every patient's different. And that's something you have to be able to discuss with your patients beyond, applying these techniques to them. So the techniques have really been, hey, let's cut the bone either in a vertical fashion, or let's actually cut the bone in sort of a V shape or chevron fashion. And it doesn't make a difference whether you do a particular type of cut. And that was the basis of our study that we completed. And so we use multiple, cadaveric specimens, and we said that, hey, we're either going to cut it in a straight line as marked out here, or we're going to cut in that V shape. And the specimens were thawed before we actually completed the relative surgeries on them. And they were performed by myself and another foot and ankle fellowship trained orthopedic surgeon. And the techniques and instrumentations were standardized between the two groups. We also looked at how much the head could actually be translated or shifted over, if you will. And once that was actually done, the metatarsal base, as shown here, was actually kind of potted or locked into place to complete the actual biomechanical testing. And failure was, defined as whether, we did this kind of loading until failure occurred, and that was defined as whether you fractured at the metatarsal head or at the osteotomy level where the bone was cut, or at the level where the screw was actually placed. And all these different biomechanical parameters were, as described here, were evaluated subsequently. So we had all male cadavers, and the amount of actual shift of the metatarsal head was not statistically significant between the two groups, either the transverse osteotomy or the chevron or V-shaped osteotomy group. And the way in which they failed didn't differ between the two groups either. And the biomechanical testing did not show any differences between the two groups either. Although when it came to the sort of amount of, or the maximal, kind of the amount of load, there was some trend, as you can see in both graphs from here to here, there was some trend towards, greater resistance in the transverse group, interestingly enough, to loads to failure. With regards to stiffness, this was not statistically significantly different either. And so in conclusion, there was no major biomechanical differences between the two groups. And there was a trend towards an increased yield load in the transverse osteotomy group, but this was not statistically significant. And so certainly, we might have seen greater values in the transverse cohort as demonstrated in the schematics here, in part because of just the way, because of how much bone was being preserved, and the fact that we were not able to move the head over nearly as much. And so that may have contributed to the relative, differences in biomechanical stability. Although the transverse osteotomy is typically unstable, it definitely gives you the ability to control for rotation a little bit more easily. But the fact that the amount of cortex that was overlapping in the V-shape or chevron group may have actually rendered it weaker because of that reduction in cortical overlap. So certainly there's limitations with any study. A small sample size, the specimens did not have a bunion at baseline. And again, a cadaver study may not translate to what we see in the clinical setting. So these are all important considerations. Furthermore, because of the nuances just described, it's hard to get the screws to be bicortical fixation, particularly the screw that's closer towards the outside of the more laterally based screw. And furthermore, tissues that were contracted may have limited our ability to actually translate the metatarsal head, interestingly enough. So in conclusion, while minimally invasive surgery is definitely becoming increasingly popular, it's not without its own sort of risks for complications, if you will. And certainly when you're deciding on the type of osteotomy to consider, particularly in a hallux valgus correction scenario, you have your choice between either a transverse or chevron. But at least in our study, we found that there was no statistically significant differences, biomechanically anyway, between the two osteotomy types, and certainly should be considered with regards to use in your clinical practice. Here are some references, and thank you so very much for your time and your attention.